No, it's fine.
All right. So let's talk about device selection. Some of the stuff, again, we've covered in pharmacology, which I know you're all excited to take that pharmacology test when you come back from break. But again, some of that is fair game. We'll touch on it, but I know Lori covered a lot of it in the past. So how do we begin? Well, we begin with, again, with our order. In this case, if we're looking for a medication order, it should have the medication, the dosage. If we're using a diluent like normal saline, and then the frequency that is there. And ideally, you should have a duration of therapy as far as how many days do you want to do this before it's reevaluated. The best way is, again, to do by protocol. That way we can upgrade it or downgrade it as needed. The term dispense as written is a one that for some medications we're dealing with the administration off-label. So Colistin was not designed to be nebulized. It's not FDA approved to be nebulized. Do we still nebulize it? Yeah. Okay, because it's been shown to be effective. Tobramycin is the same exact way. And we can, and if it's written, dispenses as written, it can't be changed via protocol. You need to contact the physician involved. And again, aerosol has a whole lot better effect on FEV1. If I'm looking at, and this is an example of a bronchodilator, I have a whole lot better effect if I aerosolize that medication than if I give it orally or subcutaneously. Basically, it's the best route of administration for drugs that are acting directly onto the tracheobronchial tree. Always got to take into account patient issues, and I think Lori had a slide on that, talking about different age and whether or not they have the comprehension to be able to do it. Where do we want the deposition to be? Do we want it in the upper airway? Do I want it in the medium to small size airways? Do I want it in the lung parenchyma? Their ventilatory pattern will make a difference. If they have an artificial airway in place, that'll make a difference. Cost can play into it, especially when we're talking about home use. And then where are we doing this? Are we doing it in the hospital or in the home? This is just kind of a rough idea as far as what kind of age range you can end up using various things with. Some of the stuff is obviously a whole lot older, but usually by the age of 4 or 5, they're able to handle pretty much any device involved. And here you see the spacer, Mike Maulmeister. Actually played sputum bowl against him at one point in time. But again, able to use it with smaller and smaller children. Again, focusing on the deposition as far as particle size, where do we want it to fall? Also depends on the lung disease involved. We've seen this slide before, and it pertains as far as medication deposition also. As far as their ventilatory pattern, there's a distinction as far as their inspiratory flow rate. For a patient who's receiving a DPI, we need a much higher inspiratory flow rate, where with in contrasting to an MDI, where we want a very slow flow rate. If their respiratory rate is elevated, you may get a little bit better response, especially with an MDI with a holding chamber or deepen flow with a breath hold. And again, if you're taking medication in through the mouth, it should be an open mouth in the process so your tongue doesn't get in the way. This is just showing total deposition based upon flow rates. So a low flow rate with a high volume, deep breath with a very slow inhalation and a breath hold you end up having better deposition involved. Keeping the child calm. If you think about a crying baby, it's a waste of time to give a treatment to a crying baby, because what are they doing? It's not going to be a very effective inspiratory phase there. So calm the child as much as possible. If that means having mom deliver the therapy, then have mom or dad deliver the therapy. Okay. What you end up seeing a lot of times is because they end up, the medication ends up being swallowed, and they end up then barfing all over the place. So very, very ineffective. And we do all kind of crazy things, like having our little teddy bear that goes ahead and actually the nebulizer connects to it, and it comes out the teddy bear's chest, and okay, whatever, as long as it works and you're able to deliver the medication. A choo-choo train that's powering it, okay, typically what we end up doing is giving it via a mouthpiece. If the patient is not able to hold it in their mouth, we can use a face mask. If the patient has an artificial airway in, we may need to do some modifications of that, and we'll talk about that in a second. And if they have a trach tube, we can actually attach it to the trach mask. Instead of having the aerosol that's coming from the wall to from the large volume nebulizer, I can hook up my small volume nebulizer to the trach mask. So what we'll do as far as probably when you guys come back on Monday after the break, we'll do a little lab and have you guys practice doing small volume nebulizer therapy on each other. Here's that same nebulizer adapted to a mask. Again, it's all the standard fittings will connect directly up. Here's one using a trach collar, and notice what we've done is we've taken that T-piece, we've capped off one end of it, and then all the nebulization that occurs will end up going to the trach mask itself and not to the atmosphere. Same is true with the T-piece. So those are the modifications we can make to the system so that we're able to adapt a small volume nebulizer to the endotracheal or tracheostomy tube. Again, costs are a consideration. We really don't get into will insurance cover it, but it's certainly something, or whether or not the patient can afford it. When they go home, it certainly needs to be at least something that is discussed. And then is the therapy going to be administered at home? Is it going to be administered at work? Is it going to be administered when they go to school? Because there's certain regulations related to that as far as school policy saying that a child cannot have an MDI on their body. They have to have it at the student nurse or the school nurse, and they have to go down to to have the administration done. And then certain drug characteristics. It's got to take into account whether or not a standard nebulizer will work, or do you need a special nebulizer like the Perry that is used for certain drugs. And again, need to just pay attention, because there are some where you have to be using a Perry nebulizer. Dornase alpha it can be used with a Perry also. So some of them have certain nebulizers that you have to use with them, and that's all that has been approved. And just another example of not only the nebulizer, but also the compressor that is used with it. And you don't need to memorize those, just recognize that certain drugs need to have certain nebulizers or compressors used with them. That was the intent of that. I'm not going to ask you which nebulizer goes with which drug. So let's take a look at our small volume nebulizer. That's the one we're most commonly used. We have a mouthpiece, the T-piece, the nebulizer itself, the capillary tube that's drawing up our flow of oxygen, where that is hooked up, and typically we have a little extension tubing on the end. So it's there. And this is just your standard small volume nebulizer. It's continually generating output when the patient is inhaling as well as when they're exhaling, and yeah, that means that we're wasting some medication. Okay. Typically, it's in the therapeutic range of 1 to 10 microns. Sometimes it gets a little more specific. Ideally, where we want it for deposition in the airway is 2 to 5 microns, so it's well within that range. The actual output varies widely, and even when within a brand, it varies widely. In other words, there's no standardized, if I'm using this one from, I don't know what manufacturer, even within that lot, there's going to be a lot of crap. If as a manager, I wanted to buy something that worked, but I didn't have a lot of waste, a lot of ones that didn't work. So it was always you can go really cheap, and when you go and purchase something that's very low cost, typically you get low quality too with it. We always got to have a pressurized gas source, whether that is oxygen or air or compressed air. And the good news is even when we do everything correctly, we still have lousy deposition. But it's better than having systemic administration with a pill or a subcutaneous injection. You're just looking at some different brands, and not only looking at the amount of particle size that we're dealing with, the mass median aerosol diameter, but also looking at whether it's vertical or whether you can use it at an angle, because they lose their effectiveness in many cases if they're not straight up and down. And why does that make a difference? Because I may have a patient who has a tracheostomy tube who's lying in bed like this at a 30-degree angle, and that nebulizer now has to be held in a vertical position, which is going to be really difficult to do. So bottom line is that there's big variance between nebulizers and within nebulizers. And again, these are just looking at particle size, how many of them, what percent are less than 4.7 microns, and you can see that there's a big difference between brands. This is just looking at a scan. You can see there's very minimal deposition. There's probably more deposition into the stomach and throat, or just swallowed. There's things that we can do to control how much output we have. Certainly turning the flow, adjusting the flow makes a difference. Typically we run a nebulizer somewhere between 6 and 8 liters per minute. There's as the volume changes, what we call the fill volume, as that is nebulized, the particle size actually and the output actually change. There's what is known as dead space volume or residual volume. At the very end of the therapy, there's always some medication left in there. And when it starts to sputter, and as you do these, you'll end up seeing, as it starts to sputter, it probably gets less and less effective continuing that therapy. Patients will insist that they have to go to the very last drop. It's like, I'm going to tell you something, the particle size, you ain't getting anything out of it. So, but we talked about nebulizer position. We've talked about reservoirs or extensions to try to save some of the medication. Other factors that affect it as far as the equipment, how the baffling goes on to remove those larger particles, what kind of gas are we using. Typically it's not a big deal, but the gas pressure certainly is. In the hospital we have 50 psi powering it, but what about in the home? Those little home compressors, are they generating enough pressure to be able to have an adequate flow in to the nebulizer itself? And again, the humidity and temperature affects particle size, as we've seen up to this point in time. And then different drugs nebulize differently. Mucimist is going to nebulize quite different than a drug like albuterol. So depending upon the model, it'll tell us what flow rate we should end up using. Typically 6 to 8 is where most of them fall. You get above 8 and you're probably, your therapy is not going to last as long, and you want it to be able to have probably a 10 to 15 minute duration. But again, sometimes there's specific recommendations from the manufacturer. This is the Misty 10 nebulizer, and for whatever reason they recommend using at various flows. You can see the duration of the therapy changes, and you can end up getting some optimal particle size. What about if I have a patient who's on oxygen? Well, certainly makes sense to keep them on oxygen. In many cases, or in some cases, if they're if they're sensitive to oxygen, in the sense that we end up seeing oxygen-induced hypoventilation, maybe the therapy should be administered with a compressed air system. So instead of plugging the flow meter into an oxygen outlet, I'm going to plug it into a compressed air outlet. Sometimes, what about if they're on a non-rebreather and they need some higher levels of concentrations of oxygen? What do we do with that? And the same is true with home care patients. It's an example of a compressor plugs into an electrical outlet and generates enough flow to power a nebulizer. Might be an option for somebody who is on oxygen and still needs to wear the nasal cannula during therapy. Some of the other ones that are available in the home, nice little carrying cases. This AeroNeb is a totally different beast, but we're seeing more and more of it in the not only in the home but also in the ICU. Whoop.
Is that a VHS thing?
It is. It is. They probably now have them on Blu-ray, but whatever. So a small volume nebulizer with a mask or mouthpiece will provide a fair amount of oxygen, 40 to 50%. So not only is the oxygen powering the nebulizer, some of that oxygen does end up being inspired by the patient. Using a mask may increase it slightly more, and if you really want to get cool, you can put a mask on and have the cannula underneath the mask. Woohoo! And again, you want to monitor with pulse oximetry how much oxygen is being administered. We talked about the nasal cannula under the mask. We can adapt a nebulizer to a non-rebreather, or we can use a high oxygen system in, there's a board we haven't pulled out yet, right? But we'll have it out so you can take a look at some of the modifications that can be made. This is that high ox nebulizer that actually a little bit expensive, but it has one powering the nebulizer, and there's a non-rebreather style mask that is, or a reservoir to hold additional oxygen. So there's ways we can modify things so that even though they're on a high concentration of oxygen, I'm going to go ahead and allow them to be able to take a treatment at the same time without disturbing that oxygen delivery. And I think I'll stop there. She don't look too happy. Or she won't be.
Yeah, she looks fine. Sleeping, not for long. I think all medicine can come with the Darwinism.